My name is Katie Lineback, and this is Ashton Whitehead. We did our project on increased intracranial pressure. So for pathophysiology, increased intracranial pressure is a rise in the pressure inside of the skull that can result in brain injury. It is caused by injury to the brain or infection. Increased intracranial pressure is defined as sustained pressure that's greater than 20 millimeters of mercury. This sustained pressure can lead to cerebral ischemia, which causes a decrease in brain perfusion and blood flow. If the pressure on the brain is not successfully treated, increased ICP can lead to herniation and even death. Some causes for ICP are too much cerebral spinal fluid, bleeding in the brain, tumor, swelling in the brain, aneurysm, blood pooling, brain or head injury, infections like encephalitis or meningitis, hydrocephalus, high blood pressure, or stroke.
So the signs and symptoms of ICP can often be mistaken for something else. It's important that if you're experiencing any of these symptoms that you go to a healthcare provider so you can get an accurate diagnosis. Early symptoms could include headaches or just differences in nervous system responses. Other clinical manifestations are going to progress to headaches that are worsening, double vision, blindness, feeling less alert, vomiting, change of behavior, problems with moving or talking, a lack of energy, or sometimes you're going to experience numbness in your extremities. We hope to catch the clinical manifestations at this point, but if they progress, they'll become late signs, which are called Cushing's triad. And this is when the blood flow to the brain is so decreased that you're going to start to experience symptoms such as hypertension, widening of pulse pressures, bradycardia, and this is actually a life-threatening, this has progressed to a life-threatening ICP for the patient. So if it's not treated immediately, it will result in death. Complications that can arise if these symptoms aren't treated are seizures, stroke, neurologic damage that's irreversible, and again, it can result in death if not handled appropriately. So when a healthcare provider is diagnosing ICP, they're going to use the symptoms that you're experiencing, and then they're also going to use a CT scan or MRI to confirm that diagnosis and to also try to find the cause. As Katie said before, there's many different causes for ICP, and knowing the cause can help to direct the proper treatment. As far as measuring the pressure in the brain, there's a couple ways that we can do this to be most accurate. There's a spinal tap that measures the cerebral spinal fluid and the amount of pressure that is within the spine. And there's also a way that doctors can drill a hole into the skull and insert a catheter that is actually directly measuring that pressure on the brain so that we can understand the extent of it and if it's growing in pressure or if the pressure is actually coming off of the brain as we're progressing with treatment.
So for treatments and management, a sudden onset of increased ICP is a medical emergency. The patient with increased intracranial pressure will be treated in the ICU. That way they can be monitored for any trends in vital signs as well as neurological status. Some patients require interventions like breathing treatments, draining of the cerebrospinal fluid, removal of part of the skull, as well as medications to decrease the swelling, such as mannitol, osmetrol, and resectosol. If there's a factor that caused increased intracranial pressure, like a tumor or hemorrhage, the problem will be treated based on protocol. We looked at some evidence-based practice for intracranial pressure. The first, the ABCs of managing increased intracranial pressure. We know it is very important as intracranial pressure is complex and changes in pressure can happen so quickly. It is important to be able to recognize the changes and follow through with treatment as soon as possible. Brain cells start dying within 4 to 6 minutes of blood supply cutoff, and within 10 minutes, irreversible brain damage can occur. The students and teachers in this particular study came up with a mnemonic, letters A to L, that help us recognize or identify these causes, clinical manifestations that will lead us to the interventions that we need to provide. Some examples are airway. We need to assess the airway. We need to look at the level of consciousness. It's important to look at blood pressure. Decompression of the stomach may be needed. It's important for that elevation of the head of the bed at least 30 degrees. We want to look at the eyes and assess for pupil changes. GCS, Glasgow Coma Scale, is important as it looks at the level of consciousness and creates a value that physicians will look at to help with diagnosis. Also, we want to prevent any kind of herniation, prevent temperature from rising. It's important to make sure that we look at the Kernig and Brudzinski sign. Those can help identify if the patient has meningitis, which relates back to the possible cause of the ICP from the infection. Lumbar puncture can be used as well. Intracranial pressure values are highly variable after cerebrospinal fluid drainage. This study showed the importance of ICP monitoring. So we talked about the external ventricular drain that is put into the burr hole of the skull that allows us to read the pressure on the brain, and this is monitored, and the nurse will look at the waveform, confirm it before they add it to the chart. This study showed that we need to monitor this waveform for at least 5 minutes to be safe for the patient with ICP. Also, inaccurate documentation can cause further harm to the patient, so we want to make sure that we're getting the most accurate waveform and that we're staying in there to monitor it as much as possible to look for any changes.
So as Katie mentioned before, the Glasgow Coma Scale is really important in documenting the client's neurologic status and if it's actually improving or if they're degressing with that status. So it takes into account 3 behavioral systems, which is going to be their eyes, your vocal, and the motor responses. So nurses are giving each of these a rating of a number value. The highest of these summed numbers being 15, which is fully functional neurologic status, and then the lowest being 3, which would be someone that's in a very life-threatening position. So it's really important for nurses to be extremely accurate with these numbers that they are charting because decisions are made by physicians based on these numbers, and interventions are decided on based on the numbers. If nurses are not accurate, then one nurse coming in may give a reading that's much different than the next nurse, and this can create an emergency for the patient when there may not actually be a change. And same goes, we may miss a change that occurs if nurses are not very specific and accurate in the documentation. So there's new studies out that use pupillometry, which is a new device that can be used at the bedside by nurses for this to make monitoring changes in pupils a lot more accurate. So with ICP, oftentimes the pressure in the brain will actually cause pressure on that 3rd intracranial nerve, which is going to affect your pupils and their response and their symmetry. So this device allows you to objectively measure the pupils and any changes in them so that nurses aren't left up to guesswork to determine if pupils are changing in their response or size. This is really important because nurses being able to accurately determine this allows them to notify the physician and also intervene much quicker than if they were to wait for the pupils to change in a way that is so dramatic that they're able to see it with their own eyes. So this study has shown that there is a much better prognosis for patients with ICP when using this, and they're able to get intervention much more quickly.
So for nursing diagnosis, for the nurses taking care of patients with ICP, first would be decreased tissue perfusion related to the increased intracranial pressure as evidenced by neurological changes, slow pupillary response, and decreased level of consciousness and change in motor response. The second would be risk for ineffective breathing pattern related to diminished level of consciousness and herniation of the brainstem secondary to the increased intracranial pressure.
So just to recap, nurses play a very vital role in the prognosis of patients that are diagnosed with increased intracranial pressure. So it's super important that they're accurate on their neuro checks. They need to be hourly and sometimes even 30 minutes based on the status of the patient. It then can be extended once you realize your patient is more stable to maybe every 4 hours or once a shift. Also are going to want to make sure that they're getting their medications, they're getting them on time so that fluid can come off the brain and that patient can start to heal and that they're not progressing to a Cushing's triad where it becomes a life-threatening situation. It's really important to make sure the head of the bed stays at least 30 degrees. Anywhere from 30 to 45 is best for the patient. If the patient lays flat, they're going to add to that fluid pressure that's in their brain, and it's not going to allow healing to take place. It's also really important to decrease the stimuli that's surrounding the patient because that increased stress can make the increased cranial pressure go up even more. We're also going to instruct our patients to avoid the Vaslov maneuver because that can also result in increased cranial pressure. And here are our references.